I would like to introduce our first speaker. Dr. Michael Koriwchak is an ENT physician who received his medical degree from Duke University School of Medicine in 1988. He completed both his internship in general surgery and residency in otolaryngology, head and neck surgery at Vanderbilt University Medical Center. Dr. Koriwchak has been working with information technology since 1977. He has 8 years of EHR experience. He has 18 years in private medical practice and over 30 years of IT experience, including building his own EHR system many years ago. So Dr. Koriwchak will be speaking to us on the opportunity to merge the medical and information technology communities and ways to bring information technology to healthcare and alternatives to the current EHR management systems. So with that introduction, I want to thank Dr. Michael Koriwchak for joining us. And Michael, we look forward to hearing your presentation.
Hello, I'm Dr. Mike Koriwchak. Thanks very much for listening to my presentation entitled Health Information Technology, What Has Gone Wrong? I'd like to thank Mike Strickland as well as Daniel Craviato and Judith Thompson and Gina Melnick for putting this meeting together and for having me along. Next slide. So we'll get right into this and start with something that I think we can all agree on, which is that despite the fact that electronic medical records vendors peddle healthcare utopia through their products, through EMR, no more paperwork, no more errors in healthcare, better care, more efficient care, all this kind of utopian stuff, I think we know better that in the real world, these products don't do so well overall. And it reminds me, because I'm kind of a car guy, of another product that came out about 60 years ago that was hailed in very much the same way. The Edsel, for those of you who are under the age of 50 and don't remember this car, was hailed by Ford as a technological achievement. With the product of tons of research, tons of marketing research, market analysis, had all sorts of neat technological advancements like self-adjusting brakes, which was a big deal at the time, and even had push buttons on the steering wheel to change gears. Ford was convinced this car couldn't miss, and it was the perfect car until the first one rolled off the assembly line and everybody realized it was a dog. The model lasted only 3 years. You can see how ugly the darn thing was. And in fact, it was so bad that the word Edsel made it into America's lexicon for several decades as a synonym for something that was a real failure or was really bad. You say, yeah, that was a real Edsel. So we can spend, the rest of my 30 minutes here talking about how bad EMRs are and how angry we are and, hammering our fists on the ground and saying we're not going to take it anymore. But that is not, next slide, going to help us very much because, the folks who support EMRs and the folks that criticize physicians for not being enthusiastic about EMRs already attack us on our message. And we enter this discussion at a disadvantage. We enter this debate at a disadvantage because their message is very intuitive. It is easy to understand and makes sense if you don't know any better, which is to say, look, computers have revolutionized every other part of the economy, right? I mean, the way we travel, the way we buy stuff, the way we go to the bank, all that has changed for the better. And so it's intuitive to think, well, if all these other parts of the economy have been improved, why not healthcare? And so when doctors are reluctant, then we get accused of being Luddites. We get accused of being old fuddy-duddies, old dogs that can't learn new tricks, or even worse, we get accused of having deep, dark secrets buried in our paper charts. And when all this gets computerized and the bright light of truth is shined on everything, that somehow there's some sort of, secret that remains to be discovered. Other sorts of nonsense. So in order to enter this discussion and discuss this at parity with these folks, we need to come up with a much clearer, more articulate message than how bad EMRs are and how angry we are. We've got to come up with something better. And this talk is designed toward giving you that more sophisticated argument. Next slide. So what is the message? We'll start with a very simple form. It's just a framework for you to follow the rest of the talk. Basically, there's two parts. Information technology has tremendous potential to improve healthcare delivery. But government intervention has ruined that idea. Government and its regulations have forced such a poor implementation of electronic medical records that, at least for the time being, for the foreseeable future, a really good idea, health information technology, has been ruined. So before we go on, I need to talk to you about what my background is here. I think it's relevant. So, of my 52 years I've been on this earth, 40 of those years I have been working with information technology since junior high school. That kind of puts me in the Steve Jobs and Bill Gates range. And I think I've been writing code longer than most health information technology folks have even been alive, much less actually doing the work. So out of those 40 years, half of that, 20 years, I've been a physician, completely finished with training, med school, residency, and fellowship. And of those 20 years, 10 of those I've had with paper charts. And then in 2004, 2005, we converted to EMR. And I've had 10 very, very successful years in our practice of 8 physicians with electronic medical records. Of those 10 years, 5 of those years were before meaningful use, and 5 of those years were with meaningful use. So I think with this kind of rule of halves that seems to follow all the way down my career, I think I have a good background to make some insights and make some observations that you're going to hear in the next few minutes. So none of this makes sense without a history lesson. We need the history lesson. So we need to go back to 2005. At that point, there was a study published by the RAND Corporation that said that EMRs were going to save $80 billion a year. Tons of money through all sorts of miraculous sort of processes. Now, I don't know how you come up with a number like that. Obviously, that's a huge gross estimation, nothing you can really hang your hat on. And of course, it comes as no surprise, and here's a big shock to all of us. The study was funded by 2 of the largest EMR vendors out there, GE and Cerner. So no surprise then, given who funded the study, that their products were going to save everybody $80 billion a year. Then came the even bigger study, and this was the clinical study. This was published in the New England Journal of Medicine in 2008, a survey of 2,600 physicians. Do you use EMR? Do you not? And whether you do or not, what do you like? What do you not like? And here's what they found out. Only 4% of physicians were using what they called a full-featured EMR. So a very small percentage of the total, 1 doc out of 25, or if you look at the end for the study, roughly about 100, maybe a little bit more. But it was interesting that among those 100 or so docs, the overall satisfaction rate was off the charts. 93% satisfaction rate, and it doesn't matter how you parse out the question, whether it's decision-making quality, communication, avoidance of errors, you get the same ballpark figure, a very, very high satisfaction rate. Now, that was the folks who were using EMR. So the folks that were using EMR really liked it. But, next slide, among the folks who weren't using EMR, right, the other 96% had a lot of concerns. This wasn't just a matter of, yeah, we like EMR, we just haven't gotten around to it yet. This was, we've looked at EMR and we really, really don't like it very much. Why don't we like it? Well, cost, obviously. And then sort of a part of that, finding a system that's compatible with your practice, uncertainty regarding after you spend all that money, how you're going to recover the investment, and more specifically, a loss of productivity, not only during implementation, but even going forward after that. So there was a dark side to all of the data. The authors of that study said, look, more study is needed, right? That's usually what's said when research is done. We need to look at this some more. They said this was a good point to sort of start the discussion, but the government, the Fed, CMS said, no, we've heard enough. We are going to act, and we're going to put into the stimulus bill that was enacted in 2008 or 2009 a program called the High-Tech Program, which includes something called Meaningful Use Program, and I think everybody in this audience knows what this is. Although it professes to improve quality of care and cost and reduce mistakes and all those things, really, we know what this was. It was a part of the stimulus bill. So it's a stimulus for the health IT industry. No surprise there. And we know this was a mistake. I mean, think about what happened here. We changed the standard of care for every single physician in America based on the favorable opinion of 100 physicians. And this wasn't even high quality data, right? This is expert opinion, right? The data is stratified, right? We all learned that in med school and residency, right? The top of the pyramid in terms of data quality is prospective, randomized, double-blind, control, et cetera, and the lowest form of data is expert opinion. Well, this was expert opinion from 2,600 doctors. So never have we changed the standard of care with so little data. Never have we changed the standard of care across all of medicine, right? Most research applies to a particular disease or a particular specialty, and so one segment of medicine may get changed at a time, but not the whole thing, and certainly not by law. All right? I mean, in conventional research, people make recommendations, but nobody's required by law to change the way they practice until now. Next slide. So we talked about this, the lowest form of medical data, expert opinion, no objective measurements, right? 100 doctors thinks it makes care better. Were there any objective measurements? Absolutely not. This was a survey and nothing more. And then the biggest intellectual mistake that the government made here was to assume that just because it worked for 4% of physicians, that the other 96% were all the same. It was just a matter of, leading the horse to water, so to speak. Well, it turns out that's not true, that those 4% of doctors, of which our practice was one, we weren't in the survey, but in 2008, we had a full-featured EMR. Those 4% of physicians are, what you call early adopters. You've all heard that term before, and it means that these are folks who chose to use that system. They like technology. They have the resources to deal with it. They have the wherewithal to deal with the frustrations. When we started this, we knew the product was going to be garbage out of the box. We knew we were going to have to massage this thing over the course of years into something that was actually useful. We're still working on it 10 years later. I mean, this summer is 10 years for our EMR. We're still not through with it. Part of it is the moving target of regulations, but bottom line is it's always a work in progress. And if you don't have the resources to do that, then it's not a good idea for you. Nonetheless, we've all been coerced into it. So, of course, what do we call this? A shotgun wedding, right? I mean, what happened after the meaningful use program was enacted? Well, no surprise, EMR use went from that 4% in 2008 to over 70% in 2014. Of course, it's no surprise the revenues for EMR vendors, for some of them, it tripled. So what did CMS say? Well, of course, they gave you the government propaganda, right? Physicians have seen the light. They now understand that EMR reduces paperwork, reduces mistakes, improves quality of care, et cetera, and all that other nonsense. But we know what the truth is. The truth is if you put a big enough carrot in front of the mule and you put a big enough stick behind the mule and beat him with it, the mule will start to walk even if it's straight towards the edge of a cliff. There's nothing here about this that proves that EMR itself is any good. And if you look at all the data that goes along with these meaningful usage statistics, you find the other side of the coin. Sure, lots and lots of docs have used EMR and gotten through meaningful use stage 1. They've purchased the system, they go into the statistics, but it turns out that after the first year of meaningful use, the usage drops off, right? An attrition rate anywhere from 17 to 21%, depending on the source you look at. And by the time you get to stage 2 in 2014, the 4th year of the program, as of last November, only 2% of eligible providers had met stage 2 criteria, had tested for stage 2. Now, that number's presumably gotten better through 2015, but we do know that CMS reduced the attestation period for 2015 from all year, 365 days, down to 90 days. So we'll see what happens in the last quarter of this year. And we have a Sermo survey from early 2015, before the attestation period changed, that 55% of physicians, over half, do not intend to participate in stage 2 in 2015. So the numbers start off good. Those are the ones CMS talks about, but they get bad pretty fast. So more history. Now we get into the study that sort of mirrors the New England Journal study where physicians were surveyed. This one wasn't quite as many, 1,000 physicians. I think that's enough. And what do you see? Is that satisfaction rate still 93%? Well, not even close. Turns out if you look at all these numbers, basically 73% wouldn't buy the system again if they had the choice. 70% say care hasn't improved. 45% say it's worse. And 66%, 2/3, are losing money on the thing. So if you kind of rough all those numbers in, the satisfaction rates probably dropped from 90% down to 30, 35%. But why did this happen? Well, you and I both know why this happened. It's because the vast majority of physicians using EMR today did not freely choose it. They were forced into it, even though they didn't have the resources, didn't have the wherewithal to make EMR work for them. They're forced to do it anyway. Next slide. So what should have happened? Well, what should have happened is the government should have left things alone and left the free market do what it's supposed to do. Under those conditions, I suspect that the vendors looking at a 4% market share but very happy customers in that 4% would have approached them and said, look, let's partner. Let's figure out what you're doing right and why it is that you like these systems so well, and let's improve our products. Let's add value to our products based on the experience of successful customers. And instead of having this explosive sort of gasoline on a fire sort of growth with EMR that meaningful use produced, which is very hazardous, as we'll get to, let's go with some steady growth. Let's go with slow, steady growth. That won't make your investors rich overnight at GE and Cerner, but it sure will be a whole lot better for patients and the physicians that are taking care of those folks. I think the safety becomes a very significant issue here. Again, we've had too much technology too fast. Let's look at another little mini history lesson here. Let's look at healthcare versus banking. Okay, so we look at banks. Banks first got their first computer, and I think this picture if you believe where I pulled it off the web, is supposed to be Bank of America's first computer that was delivered somewhere around 1959, 1960, okay? So if we assume that internet banking became ubiquitous around 2005, 10 years ago, that means that the banking industry had about 45 years to assimilate. So as the technology evolved slowly, the industry evolved slowly, they took advancements as the industry offered them, and they had plenty of time. So when it was time in 2005 for them to do this, again, not because the government forced them to do it, but because of competition, right? Bank of America did it because they knew SunTrust was doing it, because they knew that Wells Fargo was doing it. And so they got into it because of free market competition, not because of legislative fiat. So compare that to what happened in healthcare, and you see something totally different, right? We started using computers for any purpose around 1995. We didn't start seeing them in clinical practice till probably 2008. And because of meaningful use, we get a whopping 7 years to bring our level of service up to the level of bankers where internet access for your records is supposed to be required. That's this year. And oh, by the way, here's another small caveat. Healthcare is a little bit more complicated than banking. So in spite of the fact that our job is considerably harder, we got considerably less time to assimilate this technology and bring it to our consumers, our patients. And so what happens in that situation? Well, here's the big piece of data, or the big piece of information that might make the critics stop short a little bit, because this is something I don't think they've thought of, which is that computers can harm. Computers can kill. Do we know that's true? Absolutely, we know that's true. And here's an example in this particular slide. You all remember this, the Ebola thing that was going on this time last year. On September 25th, 2014, America's first Ebola patient went to an emergency room in Texas with fever, GI symptoms, and a history of travel to Africa, which was documented on his intake form, which was entered into the Epic EMR system that this hospital used. But unfortunately, that data didn't make it to the folks that were taking care of this patient, and all they saw was fever and a few GI symptoms, sent the patient home. We know the rest of the story. The patient came back 2 days later with worsening symptoms. At that point, the travel history was reviewed again, and everybody figured out he had Ebola, but we know what the outcome was. Unfortunately, that patient didn't survive. So interesting how the story changed. The story changed following this unfortunate incident. A couple of weeks later, the hospital got in front of the press and said there was a flaw. There was a flaw in the interaction between the physician workflow and the nursing workflow in their EMR system, right, which was Epic, which caused the patient's travel history to not appear in the physician's standard workflow. Now, watch the words carefully, standard workflow. Interestingly, and I'll leave it up to you to conjecture why, it didn't take a lot of imagination to figure out why 2 days later, same people got in front of the press and said, no, we goofed, sorry. The EMR was fine, there was no problem with it. The travel history was available to the full healthcare team. So look at the difference in the words. Standard workflow versus available. Now, to me, reading between the lines, I think this means that the standard screens that a physician had to navigate through to get a patient treated and discharged didn't show the travel history. But if you go out of your way and click, the mouse 10 times on 10 buttons and navigate through 5 or 6 obscure screens that you never see routinely, you might see that travel history. I think that's how you can reconcile the difference between these two statements to the press. So, and this, what really, really bothers me about this, in addition to the tragedy itself, is this concept that the health IT vendors are selling to all of us called clinical decision support. And you've probably heard the term before. Clinical decision support means, doc, we're going to make you a better doctor. We're going to make you a better doctor by serving up exactly the data that you need at the time you need it. And this is going to be a wonderful thing. It's going to make the whole system work better. Patients are going to get better care, et cetera, et cetera. Well, this was a golden opportunity for the Epic system to show what it's made of in terms of clinical decision support, right? This system should have recognized a high fever entered in the system, GI symptoms entered in the system, a travel history entered in the system, regardless of the setup and the build and all the other excuses that were offered. And if you're going to do clinical decision support, there should have been a big warning light that said, hey, doc, at 2 in the morning, exhausted, we got an issue here. We got fever, GI symptoms, and a history of travel to unusual places. Maybe you better consider unusual infectious diseases. This would have been a golden opportunity to come through on the promise of clinical decision support. And instead of a success, we have what I call an epic failure, given that this was an epic EMR, an epic failure to be sure. So what do we learn from stuff like this? Well, we learned that any technology, I don't care how simple it is or how sophisticated it is, any technology is going to have unintended consequences. And as Jane Orient said in an article shortly after this tragedy, megabytes of computerized health protocols cannot match one clear-eyed medical professional. Couldn't have said it better, so I just quoted her. We have a problem, again, an unintended consequence, an unintended cultural change, that when you put the forces exerted upon us by third-party payers and the forces exerted upon us by the EMRs themselves, you have a situation where the culture changes. And instead of patient care being the top priority, it becomes data capture, data throughput, right? A patient event, an interaction with a patient no longer is an opportunity to care for that patient and make them better. It's nothing more than a billing event or a data collection event. And that's a really, really bad thing. Obviously, this audience understands that. Also, in a sort of a different vein, but again, unintended consequence, we have a situation where compliance is favored over innovation, right? These EMR systems have to be certified with the government in order to qualify for meaningful use incentives. But here's the problem. Certification, right, compliance is so complicated and so difficult that that consumes all the vendors' resources. They can barely get compliant products out the door in time for providers to use them. And most of you probably have EMR, and you've probably lived with this difficulty in your own practices. And in fact, meaningful use stage 2 was supposed to be last year in 2014, but they pushed it back a year because the vendors couldn't keep up with the demand, much less the providers. And I could tell you stories all day about trying to reach out to our vendor to make the product better based on our experience, and all we ever hear is, well, we can't talk to you. We're too busy with meaningful use and government compliance. There's no bandwidth left to actually make the products better, to actually introduce value into the products. That's just, nobody cares, because if you're not certified, you're not going to sell. So what is the complete message, right? We went over sort of the preliminaries a few slides ago. What does the complete message look like? Well, if someone's pointing a finger to you and saying, Doc, you're an old dog that can't learn new tricks, or worse yet, Doc, you're hiding secrets in your paper charts and we're going to find them, what are you going to say to folks like that? Well, the first thing you do is agree with them and say, look, health IT is a promising concept. It certainly is. We agree with that. It definitely has the potential, keyword potential, to give better care, more efficient care, lower costs, fewer errors. All absolutely true as a concept. The problem is that, well, let's not go to problems. I got a little slide here for this. The promise of health information technology is real. You can pull this out. We agree. Definitely a potential. In our practice, in ear, nose, and throat of Georgia, our EMR saves us $24,500 per doctor per year. And I don't have enough time to go into all of those details, but suffice it to say, between not paying transcription costs anymore, managing our workflow, getting our folks out of the office and letting them work at home so we don't have to pay rent for a space for them to work in, and then changing that office space from non-revenue generating space to revenue generating space, you can absolutely get a financial return on investment from your electronic medical record system. It's doable, but you got to have the guts to open the hood, like I'm showing on the picture, get into the guts of the machine and change the way the machine runs to make things better and to leverage this system that you've already paid for. So yes, we agree with the critics. We say, yes, the EMR does have potential. Health information technology does have good potential, but you know what? It's also got bad potential. EMRs can do harm, and you can bring up the example of the first Ebola patient and use that as an example that our fund of knowledge as to how to design and build and implement and use health information technology is not adequately developed. And just like any other field of medicine, right, if you practice thoracic surgery and try to fix heart valves and do bypasses and you don't understand cardiovascular physiology, you're going to hurt and kill patients. If you try to practice infectious disease without an understanding of microbiology and antibiotics, you're going to hurt and kill patients. If, by the same token, you practice health information technology, which we are all being forced to practice, without the fund of knowledge, errors are going to occur. There's going to be errors we never saw before, like the one that killed the first Ebola patient. We're going to see these unintended cultural changes where we're more concerned about billing events than care events. And the legislation, the Meaningful Use Program, has shifted the EMR potential from good to harm. because the mistakes are multiplied. We're doing these mistakes with millions of people instead of smaller numbers where things are getting watched better. We have forced compliance at the expense of innovation, and there is no question in my mind the mistakes that happen that caused the first Ebola patient to be discharged inappropriately and die. Those mistakes happen coast to coast every day. We just don't see the publicity. Maybe the outcomes aren't as bad, but I promise you those mistakes are happening every day. We just don't have the means to capture and see them. So the bottom line, your response is, despite their potential, EMRs do more harm than good. No question about it, for the reasons we've talked about. Let me spend the last 5 minutes on the talk about what do we do now. So let's talk about what do we do now. Next slide. So how do you make your EMR work for you? Well, the first thing you need to do is mentally set aside meaningful use at first. Because remember, meaningful use is a lot of bad things, but one thing we haven't talked about yet is that meaningful use is a head game. Okay, meaningful use is a head game that the government plays on you and me to try to get us to think about health information technology in their terms, not our terms. They want you to think that health information technology is all about data collection and quality reporting and demographics and big data, because that's what they want. They want the 50,000-foot view. But that is not the way that you and I are going to succeed with an electronic medical record system. Right? We've got to remind ourselves, as you will hear many times at this meeting, I suspect, that quality of care happens from the bottom up, not from the top down. So with that thought in mind, look at yourself in the mirror and tell yourself what you already know. You, the physician, know more than the hospital, than the insurance provider, certainly more than any government, politician, or bureaucrat about what our patients need and what we need to take care of our patients. We know more than everybody else. We know more than the IT vendor who's installing and running your system. We know what we need about the health information technology as well. And that may not be as obvious to you, but you know more than you think you do about what you need from your EMR system. So what do you do with that knowledge? Well, stop being so passive, first off, right? We docs, we tend to be pleasers. We tend to be a little bit passive when it comes to things outside the exam room, right? We take our financial issues and we give them to the accountant and say, fix this. We give our legal issues and we give them to the lawyers and we say, fix this. We take our practice management issues, we give them to our administrators and our consultants and we say, fix this, and we go see patients, right? They're counting on us to walk around with these blinders on and not look beyond what's right in the exam room. And that doesn't really work well. We need to stop being passive. What I would do is start with a clean sheet of paper and insist that your vendor send somebody to your office immediately to spend not an hour, not a day, but longer than that, a couple, 3 days or a week, looking at how the system runs in your practice, where the shortcomings are, and how are you going to reconfigure the system to fix that kind of stuff. You need to take charge. You need to take the lead. So if you do that, next slide, what happens? Well, here's what happened with us. And remember, we had an unfair advantage over everyone else because we started this thing 5 years before meaningful use was there. So we had a much easier time sort of defining our own mission and controlling our own destiny than folks do now. But, I'm taking it as a matter of faith that, assuming you've got meaningful use at least done for the year, that you can do this at least for a couple of months and try to get more out of your system. So what did we get? Well, we got 3 kinds of savings that added up to that $24,500 a year per doctor, because that's what we save. We save almost $25,000 a year. Now, that's offset by the expense of the system, of course, but I think it's safe to say that we come fairly close to break even. Maybe we make a little bit of money, but I'm pretty confident the system pays for itself because of what we save. So what do we save? Well, there's 3 categories you see here. The first is direct savings. That's about $14,000 a doctor a year. Most of that is transcription, and the rest is paper supplies, all the stuff you use to make paper charts, stickers, and manila folders, and all the dividers, all that kind of stuff. Then comes space savings, right? We got rid of our file room because we don't have paper charts anymore. We let folks like our billers and collectors and surgery schedulers work from home, right? That's a free raise for them because they're not paying automotive and transportation costs, and we don't have to pay rent on the space they use to work. So it's a double savings. And then third is FTE savings, because we automated a lot of our workflows and have the computer do all of the work for us that it can, and that helps. So again, that comes to about $24,500 per doctor per year over a 5-year meaningful use program, over $120,000, which dwarfs the $44,000 that meaningful use gives you over 5 years. And oh, by the way, guess what? The meaningful use stuff completely goes away after 5 years. The savings that we get obviously go on forever, and as time goes by, the better we get at this, I think the more money we'll save compared to paper. So what do you tell your EMR vendor when you drag them into your office and say, look, we're going to fix this thing. We're going to make this work the way I want it to work because I'm the doc, I'm in charge, and I know what I need. What is it you're going to look on? How do you keep your eye on the ball here? Well, look at the three things that cost you the most, right? We've got two of them on the slide. The first is transcription. We've talked about that. When you get your EMR, you've got to wean yourself off the transcription. But then what are you looking at? You're looking at rent and you're looking at payroll. So the idea is you want the computer to do as much work as it can so you don't have to pay people to do it, and you don't have to pay the rent to give those people the space to do it. You know, can it be done? We've done it over the course of 10 years. I'm confident that that can be cloned and done in other places. And, you know, if there's more interest in exactly how we do that, I'll be glad to find an alcove somewhere if you're coming to the meeting, and we'll talk about, you know, how we did it, and that's at least a starting point. Next slide. So where can you learn more about this? A couple places. You know, Dr. Schertz is going to be there at the meeting when we do these talks live. He and I share a radio show at americaswebradio.com called The Doctor's Lounge. Comes on 8 a.m. every Thursday, but there's a rebroadcast schedule, and it's available on podcast. So I invite you to pull those up and listen to those, and you will learn quite a bit. Sometimes we talk about technology, sometimes other things, but always worthwhile. And please support us at docsforpatientcarefoundation.org. This is on the last slide. www.d4pcfoundation.org. The website for the show is there, America's Web Radio. And if you really want some detailed discussions on how our practice implemented EMR successfully, go to my blog at www.wiredemrdoctor.com. I've not posted on it in a while because I've been busy with so many other things, but we started posting kind of the how we did it stuff going all the way back to 2010. So just because the postings are old doesn't mean that they're not useful. And if you go there, you'll learn a lot of stuff. So I encourage you to do that if you want to know more about how we did it. So that's the end of the talk. Thanks very much for listening, and I hope to see you face-to-face in Keystone. Thanks very much.